most of the folks that are here tonight want to know about seasonal allergies, pollen, sneezing, itchy eyes, those kind of allergies. And there's many different types of allergic reactions. We're going to focus on some of the inhaled allergens, or what most people are interested in, things like pollen and mold and mildew and animal dander, skin. We get into some hives and that kind of thing too. Not so much getting into these type of allergies like medicines and food allergies and stuff. The way we treat allergies, you're probably familiar with. Avoid them. I mean, if you can stay out of the hay barn, and if that's what bothers you, obviously avoid the allergy. If you're allergic to cats, it's not a good idea to have a cat. We tend to treat mostly with medications that treat the symptoms, so the antihistamines and steroids and these kind of things, and they're fairly effective. And if people have mild allergies, that may be all they want to mess with. If they're more severe, they're tired of messing with all the medicines. That's the heart of what we're talking about tonight, is immunotherapy, because it's more of a cure for allergies. And the traditional allergy shots are what we've used in this country primarily. We're going to talk more about the sublingual, the under-the-tongue drops. So immunotherapy is simply giving the increasing amounts of an allergen that you're allergic to burn out or sort of rebalance the system, burn out the part that's hypersensitive and rebuild the part that balances it. So eventually you achieve hyposensitization. You reduce the symptoms caused by natural exposure to the allergen. The first randomized controlled trial, the first real study to look at sublingual immunotherapy, was published 25 years ago. In the 1990s, there were more studies showing effectiveness in kids, pediatric studies. By 93, you have the European Academy of Allergies stating that sublingual is promising. It's a promising route. In 97, we're starting to look at pharmacokinetic studies, actually really studying how does it work and really analyzing how does this under-the-tongue stuff work. Looking at how allergens are absorbed under the tongue and these kind of things, real specific research studies. 1998 showing SLIT's safety in adults and children down to age 5. About the same time, the World Health Organization accepted the use of sublingual immunotherapy. Back to the European Academy of Allergies, and now, 5 years later, they're stating that sublingual immunotherapy is justified because of the ascertained efficacy and the favorable safety profile. 2001, a big working group, allergic rhinitis and its impact on asthma, found that sublingual was effective. 2004, first meta-analysis, and that's when we go back and we find 20 or 30 or 40 studies that are smaller studies, and we pool the data to get a larger, more powerful study. That's what a meta-analysis is. And so this is a pretty big deal in medicine when we do meta-analysis, because they're more powerful. You get strong results out of the deal. And found that the sublingual was a safe treatment, which significantly reduced symptoms and medication requirements in hay fever, allergic rhinitis. Here we, 2004, some studies showing the prevention of the development of asthma. And this is a big deal in kids, and we'll come back to that a little bit. Some of the dangers of the shots, like anaphylaxis and death and things like that, and discomfort. We don't really do much with kids under the age of 12, 13 just because of that. Unfortunately, we can prevent a lot of asthma treating kids starting a lot earlier and help with their symptoms along the way. Again, safety down under age 5. I believe this study went down to age 2 or 3. How it works, mechanisms of how it works being analyzed by 2005 and 6. By 2006 and 8, again, more of these big meta-analysis studies showing that the sublingual is very effective compared with placebo for hay fever and asthma in adults and children. So between 2006 and 9, a lot of large, double-blind, placebo-controlled, randomized controlled trials. These are like the gold standard in medicine. That's a mouthful. But these are the gold standard studies in medicine, showing that, and these studies were positively powered. They were big enough that there's no question this is a valid outcome. There's different types of immunity in the body. Sometimes the cells go out and kill directly, and sometimes they do things to secrete antibodies and other chemicals. And so there's kind of two different systems. And the T cells tend to be more the ones that directly bind and take action. B cells produce antibodies. T cells, T helper cells, we're going to talk a little bit more specific because they play more of a role in allergies. And T helper cells are a certain subtype of T cell, and they're essential for both types of the immune system. They're kind of like The T helper cell especially is like an air traffic controller. There's a T helper that's called the T regulatory cell. He's like an air traffic controller that's constantly helping the immune system decide what to do. Should it attack that bacteria? Should it attack that virus? Should it leave your own pancreas alone? You know, so it learns to balance the system. And within the T helper system, there's several different subtypes, and this is the part that ties in really more specifically with allergy and how the immunotherapy works. T helper 1 is a type of T helper cell that's mostly concerned with fighting pathogens that get inside the cell, like viruses and certain types of bacteria. T helper 2 is a type of immune cell that primarily helps against extracellular pathogens or bacteria that are outside the cells. And so they're kind of different. They have different battalions, different ways of fighting battle, because it's a different threat. Well, the T helper 2 is essential for the one that helps the B cells make these antibodies that we find in allergies. So IgE are antibodies. These are proteins that go out and bind to invaders. And the IgE are the ones that we see in allergies. There's other types of T helper cells, follicular cells, and T17s, but about 10% of these T helper cells are these air traffic controllers, the T regulatory cells. And the take-home point right here is just to show that they secrete these chemicals called cytokines, and that's how the immune system talks to itself. Things like interferon, you may recognize that name, interleukins, and these type of chemicals. And that determines which battalions get called into battle and exactly what the whole system does. Well, there's one called interleukin 10, and it can inhibit either one of these responses. And you're going to see here in a little bit that allergies are a T helper 2 response gone wild. And so there are things that we can do to balance that. And that's why I want you to know about these two systems. This slide shows a lot of information, but honing in on this T helper 2 all the way across. Normally it fights bugs that live in the extracellular outside environment. If this system gets a little bit out of control, we start seeing asthma and IgE-mediated allergies. So it's associated with what you think of as allergies, when this system's misbehaving, when it's overreacting. This slide shows you some details about how invaders or antigens or pollen come into the body and start being presented to the T helper cells. The point of this slide is to show this negative feedback. It's like a teeter-totter or seesaw. So if this T helper system is hypersensitive or on overdrive, you can stimulate the T helper 1 system to bring balance back to the immune system, and vice versa. That's the whole heart of this immunotherapy. Immunotherapy we'll come back to a little bit. A lot of specific mechanisms aside, we know it helps upregulate, stimulate the T helper 1 pathway. And that's how it works over time to reset the immune system. So it resets it at a level deep, deep, deep in the hard drive, so to speak. That's why it's more curative. There's 4 different types of immune reactions in the body. The first one that was ever described back in the 19-teens, I believe, was the first type 1. That's why I call it type 1. And that's the IgE. That's the one that we associate with allergies. A bee sting, we swell up. Hives, those are your allergies. But in fact, there's three other reactions. And doctors, especially naturopathic type doctors and people, refer to these other type things as sensitivities or intolerances, like food sensitivities. But in fact, it's an abnormal immune response. So they are allergies. So you'll hear that under different names if you hear people talking about food sensitivities and things. And all 4 of these immune reactions cause an abnormal immune response. Type 1 is the one we're going to hone in on tonight. These are ones that occur quickly. They're called immediate hypersensitivity. You get stung by a bee, poof, it swells up quick. You eat a strawberry and your throat swells shut, boom, quick. You go in the hay barn, your eyes swell up quick. These are all IgE, immediate hypersensitivity. And pretty quick after you get exposed, it involves these cells called mast cells, basophils, and eosinophils. And they release histamine. And that starts this whole process. I'll come back to this a little bit. After this review, there were 4 cases of reported anaphylaxis. And these were people that were getting multi-allergens at the height of pollen. Some of them actually took a much higher dose. So basically there haven't been any anaphylaxis with this, essentially. If there's mast cells in your skin, and I give you the shot in the skin, you're flirting with provoking a huge reaction, so that's why the skin route is more dangerous. Under the tongue, they have some mast cells through the gut, not right under the tongue. So you essentially can't have that reaction because you're not priming, you're not hitting the pump that's primed. General safety issues, identify known risk factors. If you have asthma and it's out of control, that's a known risk factor. I'm not going to start you on this right in the middle of something like that. There's no consistent correlation between adverse effects and the dose or between how quick we increase the dose. It's been safe in children down to age 3. A couple studies showing multi-allergens are safe and how to use these at home. General safety. These are just general things to think about. A good example, we had a man last fall who came to see me for hormones or something, and he had allergies, hay fever. He also had a bunch of gut, gas, bloating, digestive complaints. So we did both. We tested for his delayed food allergies, and we tested for his hay fever, pollen, immediate allergies. And it worked out such that he did the food allergy stuff first, and he eliminated wheat and dairy and some common food allergens. And in 2 or 3 weeks, his 20-year sinus congestion was just gone. And so, we never even ended up giving him the immunotherapy. He had some positive findings to ragweed and whatever, but it wasn't that severe when it was all said. So what we do, we take a general history and physical exam. If people have asthma, we might do some lung studies. We do skin testing, or we do the radio absorbent blood test. We go through the risks and benefits, which you guys basically got the deluxe version of that tonight, and symptom management. We start the induction maintenance phase. At the first 60-day supplies is the induction phase, and really it's just the first 10 days, and then you're on the maintenance dose from there. And then maintenance visits every 60 days to check on progress and resupply the allergen, make sure everything's going okay. The skin test is arguably the best test because you're testing the system. You can see the reaction. The blood test, you may or may not get an antibody rise that correlates with the degree of your body's reaction. So most allergists and specialists would agree that the skin test is probably the gold standard. The program cost that we do is $100 a month, just straight up includes everything, the office visits, the drops. We give people an epinephrine kit. I told you there wasn't basically not any reports of anaphylaxis in any of these studies. I'd still just send people with the epinephrine kit in case I sleep better at night, just knowing that there's no worries. This is the skin test we use by Greer Labs. These are the same company that makes our antigens. Now, Greer is a company that makes the antigen. He makes the little vials of the pollen that you use in the therapy, and they've been doing it for 100 years. And so when an allergist calls and you have 6 things that you tested positive to, they send you those 6 vials. And traditionally we'd mix them up and put them in the shots and cereal dilutions, etc. We just have them in the test kits and also in the sublingual immunotherapy. So this is a test kit. There's 40, in this kit there's 40 little bitty individual test things here. What you do is have the antigen mixtures, and these are single-use tests right here. This one's going to test 10 different antigens. There's tiny little bitty tines on the tip of these. You can't even hardly feel them. It's not like a shot, really. They're really on the surface. So it's very controlled. You lay it on the skin, rock it. It's pretty well done. I don't know if you can see there's a little bit of reaction there. And then we measure how big of a lump you get. You don't measure the red spot so much.